Hello, and thank you for joining us today for this OncLive peer exchange on the topic of precision medicine in breast cancer. In today's discussion, I'll be joined by an international panel of experts in the field of breast cancer research to discuss the very latest advances in systemic therapy. We will cover the data that have come out over the last few months, including information from the ESMO 2016 Congress. In addition, we will provide practical advice on how the data can be used to make decisions about treating your patients, both in operable and inoperable settings. I am Dr. Adam Brufsky, and I am a professor of medicine at the University of Pittsburgh and the Associate Director for Clinical Investigation at the University of Pittsburgh Cancer Institute. Participating today on our distinguished panel are Dr. Ahmad Awada, Head of Medical Oncology Clinic at the Jules Bordet Institute of the Free University of Brussels in Brussels, Belgium. Dr. Hope Rugo, Professor of Medicine and Director of the Breast Oncology Clinical Trials Program at the UCSF Helen Diller Family Comprehensive Cancer Center, and Dr. Michael Untch, Head of the Clinic for Gynecology at the Gynecologic Oncology and Obstetrics, and Head of the Interdisciplinary Breast Cancer Center of the Helios Klinikum Berlin-Buch in Berlin, Germany. Thank you all for joining us, and now let's begin. So the first thing we really want to talk about, I think, to start, is the therapy of HER2-positive breast cancer in 2016. And I think we all know this really was and has been one of the great successes, I think, in systemic therapy of breast cancer. Michael, can you start by talking a little bit about the neoadjuvant therapy of breast cancer with HER2-positive disease and kind of how we got here?
Yeah, absolutely. We have seen a tremendous development in the treatment of patients with HER2-positive disease. And as you might remember all, we started in the metastatic setting by using the first antibody, monoclonal antibody, which is trastuzumab. And then we moved on to earlier stages of cancer, which is adjuvant therapy. And the idea then was to also use trastuzumab, an anti-HER2 therapy, together with chemotherapy in patients with locally advanced or even early breast cancer, but instead of starting with the surgery, to use it before the surgery. And that was a good idea because we have a lot of data on that. And today we can tell that neoadjuvant therapy with the addition of trastuzumab is one of the standards of therapy in breast cancer patients. And by the way, in our national guideline in Germany, this is one of the way which is preferred to treat patients with HER2-positive disease. So we use it mostly in the neoadjuvant setting. Number one, the patients see that the tumors are responding quite well, so the tumors are shrinking. Number two, we do less surgery after neoadjuvant therapy because tumors are smaller, lymph nodes who have been involved are then free at the time of surgery, so we do less axillary surgery. And number three, we see pathologic complete response rates which are in the region of 50 to 70%, which means that the tumor in the lymph nodes and in the breast are melting away. Patients are tumor-free at the end of neoadjuvant therapy with anti-HER2 treatment, and we know from meta-analysis of large neoadjuvant trials that those patients are doing excellent during the follow-up. So the achievement is higher PCR, higher survival of the patients. So what we do today, we try to attempt to do new developed studies in which the pathologic complete response rate is higher.
So the question is, I think that TH, that is a taxane and trastuzumab, has kind of been the standard from a lot of these trials like NOAA and a few other ones. And now we've tried to add things to it, again with the idea, I think, of increasing pathologic complete response rate. So the question I have, because we have an international audience in front of us before we start talking about the individual drugs, the US FDA has allowed pathologic complete response rate to be an endpoint for approval in studies. Ahmad, does the same thing happen in Europe? Do the European authorities, guys, allow that?
No, not yet to my knowledge. It's not yet, let's say, approved as approach in the neoadjuvant setting. But from my point of view, I think this is really, as Michael mentioned, is a very nice approach to give our patient. And I would add something very important to Michael's introduction, that the concept of dual inhibition, which was really studied, dual inhibition of HER2 in the neoadjuvant setting, which really increased significantly the pathological complete remission. And we know what is the importance of pathological complete remission for the outcome of our patient. So this is, in my opinion, one really of a major advance in the field of HER2 disease, is the neoadjuvant setting, to increase this pathological complete remission by doing this dual HER2 inhibition.